We have Dr. Adnan Qureshi here. He's pretty world-renowned. He's a neurointerventionalist on top of a neurologist, and what that actually means is he's able, if you have a stroke, to go inside your brain, look around, and perhaps remove a blood clot or whatnot. He also does other procedures that are inside the vessels of your brain.
Okay, well, thank you so much for having me here. So essentially, this would be more of a casual format, and essentially feel free to interject and ask questions if you feel like there's material that should be discussed in more detail. So essentially, I thought I'd first give you a little bit of introduction into stroke prevention. So before we start, how many of you actually experienced a stroke or know someone who has actually experienced a stroke? Can we have? So it looks like you actually already have some familiarity with the disease stroke. And then the question becomes is that, why should we actually think about stroke? What is so scary about stroke? And many will say it's a painless disease compared to some of the other diseases that we know. And most people who suffer stroke don't really die from stroke. But stroke can cause disability. And disability can be a significant issue for people who are highly functional. And instantly their life changes overnight. So they are one day highly functional individuals who are very active in their lives, and after stroke, they are highly dependent on other individuals. So obviously it's a very concerning disease from that particular perspective. And surprisingly, if you look at the psychological consequences on the people who suffer the stroke and the people who are around them, it is a substantial psychological burden as well. In addition to, of course, the emotional, the physical, and financial burden. So I think therefore, that is a disease that really does require careful consideration. And regardless of the treatment that is available for stroke, nothing can beat prevention. And I don't think ever nothing will be able to beat prevention. So if you can prevent a stroke, there's never going to be a better option. And treatment will always have its limitations. So then it comes down to how many of you've taken a detailed perspective and have made almost an introversion to see what is our risk of having a stroke. And today we actually do have means to at least have some estimation of what is your risk of having a stroke over the next 10 years. And this is almost like a calculator, and it's actually on the web. So you can actually just enter all these fields that are there, and you will actually get an estimate of what your risk would look like in the next 10 years, and perhaps use that as a guiding light, that perhaps this may be a wake-up call to do something different than what you're doing already. And the things that you need to put in there, obviously, age is one, gender is important, race is actually important. Now also the values for cholesterol. And if you recall, all of you probably have gone to physicians and have seen the blood test. And it comes down to total cholesterol, the high density lipoprotein cholesterol, the LDL cholesterol, which is the low density lipoprotein cholesterol. And essentially, if you know the values for these two parameters, you can enter it. And obviously, whether you have diabetes or not, whether you're already on treatment for hypertension or not, what is your blood pressure, the systolic blood pressure. So if you look at your blood pressure, it always comes at like 140 by 90. So 140 is the systolic component, and 90 of course being the diastolic component. And the systolic one obviously is more important from determining the risk of actually having a stroke or heart disease, and whether you actually smoke or not. Now I'm just going to ask a show of hands, how many people actually know the parameters or have access to the parameters that would allow them to fill the values in this computer or this calculator?
What was, we have the what?
The numbers, numbers.
If we were to give you this calculator right now, do you have enough information to fill this calculator for yourself?
No.
But it seems that most of the people don't have that information. And I think that is important, that perhaps that information already exists in your medical records, and to be more familiar with that information. And one parameter that you can get today, Ms. Alicia is providing you, is the blood pressure. So I think that it probably gives you some insight that we can actually be more cognizant of what our risk for stroke is. And we just need to make that effort. Now the question becomes is, what are the risk factors for stroke? And this is actually a list which I created. It definitely lacks the sophistication that you may see in some of the web-based systems, but I think that it does carry the message. So these are actually some of the risk factors that actually we know about. A actually stands for apnea, sleep apnea. And essentially, sleep apnea is one disease that is so underdiagnosed that it's amazing. How many people actually do have sleep apnea and how many actually do know that they have sleep apnea? And it's such a big mismatch. Because sleep apnea can manifest in different ways. Meaning you just have bad sleep, you're always tired in the morning, people tell you snore at night, and all of that could manifest as, could be the manifestation of sleep apnea. So, sleep apnea is one thing to be aware of, learn more about it, and essentially if you feel that you are having the manifestation that you may have sleep apnea, I think it would be time to discuss it with your primary care physician. And actually one thing I would say is that if you have actually suffered a stroke, surprisingly your risk of sleep apnea is much higher, because sleep or stroke does affect some of the muscles that actually are responsible for breathing. So you may actually not have sleep apnea before stroke, you may develop it after stroke. Of course, B being blood pressure, and I think that all of us know about that elevated blood pressure increases the risk of actually having a stroke. And it's a linear relationship. Your risk is higher if it's 140 millimeter of mercury, becomes higher, if it's 160 millimeter of mercury, it keeps increasing in a linear fashion. And the lowest risk actually is not at 120, it's actually 110 millimeter of mercury. But practically it's very hard to actually somebody to have a blood pressure of 110 millimeter of mercury, and a lot of people start feeling dizzy and be very uncomfortable at that blood pressure. So 120 becomes a more pragmatic value that one can live with and yet have a low risk of having a stroke. And then of course cigarette smoking. I think that over the last 40 years the literature is actually full of cigarette smoking being a risk factor for stroke. And it's surprising that how many people still continue to smoke. So, but one thing I've actually noticed is that having a stroke can be a strong incentive to quit. So I think that, but one can take the hint earlier and perhaps actually quit smoking even before we get to a point that it becomes detrimental. Now if you quit smoking, your risk is not going to become normal immediately. It will take around 5 years before the risk will actually become normal. So you have to be understanding that perhaps it's a message more for the next generation that you meet and coach every day, that the risk of cigarette smoking is not going to stop immediately. If they continue to smoke, it's really bad. If they stop smoking, it still continue to be bad for the next 5 years. Now of course diabetes mellitus. Now people who have diabetes mellitus do have a higher risk of having a stroke. But actually it's surprising that if you treat their glucose very aggressively, it doesn't really change the risk. So somehow the higher risk in people who have diabetes is not really mediated by the glucose levels in their blood, but perhaps to some of the other mechanisms, for example, alteration in the blood fatty acids and some of the cholesterol mechanisms in the blood. Of course, E is for ethanol or alcohol, and alcohol use has always had a certain bad connotation to it, independent of stroke. But it seems like if you drink alcohol in moderation, it may not increase your risk of having a stroke. However, you drink alcohol in excess, it will increase the risk of actually having bleeding in the brain. So you do have to be careful that if you are actually consuming alcohol, you have to know where that limit is. Now F is for fat, and essentially the biggest danger is actually with the invisible fat, not the visible fat. And invisible fat is what we call as fat that's circulating in the blood. So you can't really tell unless you do the blood test. And the one fat or the component of fat is really what we call as LDL cholesterol. So next time if you look at the report that you have from your laboratory, try to make out the components that get in the results. There will be the total cholesterol, but there will also be the LDL cholesterol, and that seems to be more specific in predicting the risk of actually cardiovascular disease. Now G is for genetics, and this is actually a very common question, that my parent had a stroke, am I at risk of having a stroke? And the most common or the most pertinent answer is no, you're not at high risk. So essentially, unless they had a stroke at a very young age, it doesn't really change your risk of having a stroke. So the only time having a family member who had a stroke can make a difference in your risk of actually having a stroke is if they had an intracranial aneurysm or a brain aneurysm. That is the only form of stroke that can be an increased risk for you if your parents actually did have a stroke. But otherwise, if your parents had a stroke, it probably doesn't reflect on you actually having a stroke. Now, H is for heart disease. And the heart disease that probably the one that predisposes you most to having a stroke is atrial fibrillation, AF. And what is atrial fibrillation? It's just abnormal rhythm in the heart. Now, what that abnormal rhythm comes with is abnormal contractions of various chambers in the heart. So because the heart is beating at an abnormal rhythm, unfortunately it cannot contract well, so the blood starts to pool in those chambers. And whenever there is pooling of blood, clots will form. So essentially that's another risk factor for having a stroke, atrial fibrillation or heart disease. There are always these genetic or congenital heart diseases, but they're so rare that most people don't have it. And if they have it, they probably know about it when they were a child. Now, I is for inactivity. And increasingly, the information is coming that regular activity level prevents strokes. Doesn't matter what you do, it does prevent strokes, independent of all these other risk factors. How it works, perhaps maybe even having a better risk factor profile, but there seems to be some mechanism that we don't understand well. Now, what does regular exercise really mean? Regular exercise means moderate intensity exercise. So moderate intensity could be cycling, walking, jogging, but not high intensity. So no need to go to the gym and start lifting 500 pounds. That's probably unnecessary. But also it has to be to a certain duration. So a lot of time people just do like a little jogging, 10 minutes, and that's over. And that's not enough. It has to be at least 45 minutes a day. So 3 times a week, 45-minute session is what is required. But actually, a lot of time people confuse the intensity with the regular nature. It doesn't matter how intense the exercise is. More important is if you do it regularly. So no point in doing 1 week of intense exercise and then forgetting about it for the next 3 weeks. It will not give you the benefit you need. And actually, people say, well, I've had a stroke. Or, what shall I do? Should I actually become active again? And I generally tell them, live your normal life. If you're less active, your risk of actually having another stroke is higher than if you're active. So do not stop yourself. Whatever you can tolerate, go for it. I encourage them to go get yourself some kind of a regular exercise paradigm, whether it's cycling, walking, jogging, swimming, whatever they choose. So these are some of the risk factors for stroke. And essentially being more cognizant about these risk factors and intervening early if you realize that you have one of these risk factors or more of these risk factors, perhaps could actually change or could be a major shift in destiny in terms of actually having a stroke or not having a stroke. And again, I want to emphasize that yes, there are so many treatments for stroke, and perhaps the treatments will only get better, but nonetheless, prevention will always trump actual treatment or acute treatment, always. Now this comes as, how does stroke present? How do I know actually I'm having a stroke? And strokes actually come in all sizes and shapes. You can actually have strokes that you are not even aware of that you had a stroke. And then somebody will just do an MRI and say, wait a minute, there seems to be this stroke in your brain, and you never felt it. So that is a totally asymptomatic event you can have. And a lot of people do have that. You can have minor events, just felt funny for a few minutes, your speaking was changed, your hand was more clumsy, and then it just went away. Now, a lot of time people ignore that because, in 10 minutes they're back to normal. So, okay, well, it was a temporary event, I'm back to normal, I can continue with what I need to continue. But even those, what we call as mini strokes, and I'm sure Alicia will talk more about that, or we call as TIAs or transient ischemic, are warning signs, so do not ignore. That means that something bigger is coming on. And if you look at it, people who actually have TIAs, 1/4 of them will have a major stroke within the next month. So it's not even a lot of time to think about it. You have to act on it. And essentially, even in the medical profession, there has been a change in how we approach it. Previously, you could have this mini event, you would be seen at an emergency department and they'd say, okay, fine, everything is back to normal. You can go make an appointment to see your primary care physician, which will be in the next 4 to 6 weeks. And then a lot of people were actually having stroke before they even made it to that appointment. So now people have said, no, this is not the right paradigm. We have to properly address this. So now, if you have a mini stroke, essentially, there's so much emphasis on that you need to be seen by the expertise that is available in the next 24, 48 hours. You cannot wait longer. Because essentially, if you wait too long, the thing that you're trying to prevent may have already occurred. And obviously, then there are the severe strokes where you may actually end up in a coma. So there is a whole spectrum of strokes that you can have. But I think it's important to recognize because there is actually treatment. So I think recognizing early will always be important. And even if you feel that you're not at risk of having a stroke, you may be in a scenario where somebody else is having a stroke. And your recognition could make a difference in life and death for that individual. So I think that, as Alicia will talk more about how to recognize a stroke, I think that's a very important component and I will encourage you to actually pay attention and ask a question about how best to recognize stroke.
So I'm going to go through some other signs and symptoms of stroke for everyone, okay? So there's a little bit of a change in it. So initially, you might have heard of something called ACT FAST or FAST, right? Okay, so just recently, the American Heart Association has decided that they're changing it to BFAST, right? Because what was happening was the FAST that we taught everyone wasn't catching the strokes that were occurring in the back of the brain, right? So now it's changed to BFAST. So before, it was face, arm, speech, time, okay? Now, these are the signs and symptoms of stroke that we watch out for people, okay? And the first one you see is balance, so it's BFAST. The first letter is balance, okay? Very important. It's an acute change, right? So all of a sudden, it's a change in your balance. You're all of a sudden dizzy. I've been dizzy since 2 o'clock and I can't figure out why. That's a sign of a stroke in the back of your brain, okay? The next one, eyes. It's a change in vision. It doesn't have to be in both eyes. It can be in one eye, okay? That will be another sign. Then you have your face, and when we talk about face, do you know what we're looking for? We're looking for drooping in the mouth. That would be the one that's the most prominent, right? So if you ask that person to smile, one side of the mouth might go up and the other might just stay there. It doesn't necessarily have to be drooping, right? It could just be staying there and the other side can move up, okay? Next, we're going to talk about arms, okay? So when we talk about BFAST, we talk about arms. What are we talking about for the arms? Do we know? Weakness.
Oh.
Weakness. So if you're looking at someone and they're talking to you and you start to feel weird about maybe they're having stroke symptoms or not, ask them to hold up both arms, right? Like this, okay? You might see this. That's called an arm drift, okay? So for patients that are having stroke symptoms, they can be affected on one side of their body, so that one arm might drift down, okay? Another thing we talk about is speech. It can be slurred, it can be garbled, they can just not make sense. They cannot understand what you're saying, right? Speech changes. It's another sign, okay? And then when we talk about T, we always talk about time. And the reason why we talk about time, why it's so incredibly important, is because for each minute of this patient having a stroke, 1.9 million brain cells are dying, okay? For each stroke that's not treated, it accelerates your life by 36 years, okay? Yeah, so we want to be able to catch these signs and symptoms early. We want to be able to get you into the hospital early, and why? Because we could possibly intervene and we could possibly stop these strokes, okay? If it's a stroke from a blood clot, we can give you a medication if you fit all the right criteria. One of that most important criteria is you should be at the hospital before 3 hours from the last time you were normal. Does that make sense? Not 3 hours since somebody noticed I had symptoms, but 3 hours since somebody said, I looked at you and you were normal, and now you're not normal. Get into the hospital as soon as you possibly can, okay? We can potentially give you a medication. It's called TPA or Alteplase, and it can actually eat the clot, okay? That's one of the interventions that we would potentially be able to do. The other one is what I talked about with what Dr. Qureshi is able to do, is they could go inside your brain potentially and be able to remove the clot. They actually go in through your groin up to your brain and physically take the clot out of your body, and it restores the blood flow to your brain. Same thing with that one. The faster it happens, the less likely you are to have permanent damage to your brain. Okay? So that's why it's incredibly important to get to the hospital ASAP. Okay?
I think one thing worth mentioning is that if you see that somebody is having a stroke or you feel that you're having a stroke, don't try to get to the hospital yourself. Call 911.
Yeah,
There is clearly numerous times it has been shown that for getting time-efficient treatment, you must go through the 911 system. Do not try to drive yourself. It doesn't matter how fast a driver you are. Even you drove for NASCAR once, that's not the way to go.
Yeah, absolutely.